Now we're going to start talking about the male genitourinary agents. Benign prostatic hyperplasia. BPH is a benign neoplasm of the prostate gland that, if large enough, causes voiding dysfunction. BPH, which is extremely common in the aging male, occurs in less than 10% of men aged 31 to 40. However, by age 60, nearly half the men will develop BPH, and by the age of 85, more than 80% will have it. Prostatism has three components: histologic prostatic hyperplasia, an increase in outflow resistance, and response of the bladder muscles to obstruction. The prostate depends on the androgen 5A dihydrotestosterone (DTH) for growth. The enzyme 5A reductase metabolizes testosterone to DTH in the prostate gland, liver, and skin. DTH induces androgenic effects by binding to androgen receptors in the cell nuclei of these organs. The medical history focuses on the urinary tract and on overall health problems that could affect urinary symptoms such as diabetes, Parkinson's disease, and stroke. It's important to rule out the possibility of prostate cancer. Medications that can affect bladder function include anticholinergics and sympathomimetics. The American Urological Association symptom score for BPH is commonly used to assess symptom severity, but not for diagnosis. The patient's symptoms score is calculated from the answers to 7 questions on a scale of 0 not present to 5 almost always present. These questions address urinary frequency, nocturia, weak urinary stream, hesitancy, intermittence, incomplete bladder emptying, and urgency. The system score of 0 to 7 is mild, 8 to 19 means moderate, or 20 to 35 severe. The AAU symptom score has also been shown to be effective in visually impaired and illiterate patients. Physical exam emphasizes the digital rectal exam and the neurological system. The digital rectal exam is essential to estimate the size of the prostate gland, to evaluate the anal sphincter tone, and to raise suspicion of prostate or rectal malignancy. Laboratory tests required to assess renal function include urinalysis, serum creatinine, and BUN. The PSA is considered optional under some guidelines. Other tests that may be performed include uroflowmetry, post-void residual, and pressure flow studies. Tests that are not recommended are filling cystostomy, urethrocytoscopy, and imaging of the urinary tract, unless these are indicated by prostatism complicated by additional disease or symptoms. So again, for the benign, for BPH, we use the alpha-1 adrenergic agonists, such as alpha-1 selective medications such as Flomax, long-acting alpha-1 Cardura, short-acting alpha-1 Minipress. The 5A reductase inhibitors include Proscar and Atodart. For erectile dysfunction, the PDE5 inhibitors are used. They also have unlabeled uses, include treatment of erectile dysfunction resulting from vascular or diabetic origins, or from the use of serotonin reuptake inhibitors. Also used for orthostatic hypotension and as an aphrodisiac and for pulmonary hypertension. This includes Rivato, 20 milligrams. Carvajet is used for the treatment of erectile dysfunction resulting from neurogenic, vasculogenic, or psychogenic causes, or erectile dysfunction of mixed origin. Yocon has no indications approved by the FDA. However, this is used for erectile dysfunction. Erectile dysfunction is defined as a constant inability to maintain or erect an erect penis with significant rigidity to allow for sexual intercourse. It is common and frequently increases with age. Erectile dysfunction may result from malfunction of one or more areas. Causes are characterized into psychologic or organic causes. Psychological causes are usually abrupt in onset, and incidence varies with partner, position, or situation. This type occurs more commonly in younger men. Organic causes usually have gradual onset and are consistent. Newer studies find that men with severe periodontal disease have a higher risk for erectile problems compared to men with healthy gums. Workup for erectile dysfunction should include complete history, including information about sexual history, emotional upheavals, and any drug use. Testing may include measurement of nocturnal penile transience with mechanical and elective devices. Neurological causes can result from diabetes, multiple sclerosis, spinal cord damage, nerve damage after a prostatectomy, decreased blood flow because of atherosclerosis, and vascular damage resulting from injury. This would include renal transplant, bypass procedures, hyperprolactinemia, and structural abnormalities. Numerous drugs may also be responsible, such as antihypertensive, opioids, antidepressants, anti-anxiety agents, antipsychotic agents, ethyl alcohol, chemotherapy agents, cimetidine, and estrogenic agents. While men who have cardiovascular disease may develop erectile dysfunction, current research suggests that men who have erectile dysfunction are at increased risk for cardiovascular disease, particularly silent coronary artery disease and MI, stroke, and death. ED may not only contribute to cardiovascular risk prediction, but also may serve as a potential target for cardiovascular prevention. Much more research is needed in this area. So for the BPH mechanism of action, the non-specific alpha-1 adrenergic receptor blockers, such as terazosin, doxazosin, prazosin, reduce sympathetic tone and relax urethral stricture that causes BPH symptoms. Prazosin has a shorter duration of action than the others and generally is not used first line. These drugs also lower blood pressure by blocking alpha-1 adrenergic receptors on arterioles, causing vasodilation. Newer selective agents such as tamsulosin and alphazocin are specific for the alpha-1A adenoreceptors in the prostate, and they have little effect on blood pressure. Finasteride reduces the size of the prostate gland, but 6 to 12 months may be required for improvement of symptoms. It is a 5-alpha reductase enzyme inhibitor that blocks the conversion of testosterone to dihydrotestosterone, the potent androgen upon which the development of the prostate gland is dependent. Dutasteride is a second-generation 5-alpha reductase inhibitor. It inhibits both type 1 and type 2 5-alpha reductase. For cardinal points of treatment, first-line treatment is an alpha-1A selective agonist for patients without hypertension, long-acting alpha-1 antagonist for patients with hypertension given to reduce symptoms. 5-alpha reductase inhibitors are given to shrink the size of the prostate. However, 6 months of therapy is required to achieve the maximum benefit. Combination therapy with alpha-1 antagonist plus an 5-alpha reductase inhibitors can be used. For BPH, surgery is primary treatment. Treatment is initiated when symptoms become problematic. All alpha blockers are considered equally efficacious. Alpha blockers are the best for quick symptom relief. the 5-alpha reductase inhibitors can prevent growth of the prostate over long term. Goals are to help with alleviating symptoms and maintain kidney function. So how do we monitor these patients? We need to monitor for symptom relief using the AUA symptom scale, monitor closely for complications of BPH such as obstructive uropathy, and monitor for sexual side effects. Patient variables for geriatrics, BPH is very common in the elderly man. Pregnancy and lactation, these medications are considered category C other than alpha-1 adrenergic blockers. Category X, such as finasteride and dutasteride. These meds are heterogenic. They must not be touched by a woman who are pregnant, because the product may be absorbed through the skin. A pregnant woman should not come in contact with the semen of a man who has taken finasteride. For gender, tamsulosin, afusocin, and dutasteride are not indicated for females. Patient education, the patient should report immediately any signs and symptoms of obstructive uropathy. Finasteride and dutasteride are tetragenic. They again should not be touched by a woman who becomes pregnant, because it may be absorbed through the skin. FDA has issued warning of an increased risk of high-grade prostate cancer while taking 5-alpha reductase inhibitors, and combination therapy with finasteride and doxorubicin has shown to lower the risk of clinical progression of BPH by 66%. Herbal treatment with saw palmetto is popular. It acts like a 5-alpha reductase inhibitor. For mechanism of actions of the PDE5 inhibitors, erection involves release of nitric oxide in the corpus callosum in response to stimulation. Nitrous oxide increases the level of cyclic guanosine monophosphate, or CGMP, producing smooth muscle relaxation in the corpus callosum and allowing inflow of blood. PDE5 is the enzyme that breaks down CMP in the corpus callosum. PDE5 inhibitors inhibit this and allow for increased blood flow to the penis, resulting in erection. The PDE5 enzyme is very specific to receptors in the corpus callosum. Smooth muscle is also found in much lower concentrations in platelets, vascular and visceral smooth muscle, and skeletal muscle. PDE3 is found in cardiac contractility. Therefore, these drugs are not active for this condition. They're closely related to PDE6, which may explain the abnormalities in color vision seen with patients taking PDE5 inhibitors. Tadalafil has a different chemical structure than sildenafil and verapamil. Has less affinity for PDE6, which affects the retina, but greater affinity for PDE11. PDE11 is found in skeletal muscles, testes, heart, prostate, kidney, liver, and pituitary. The clinical significance of these differences is not really known. Carvaject is a prostaglandin that has many physiological actions. Vasodilation and inhibition of platelet aggregation are the most important of these. It induces erection via relaxation of the trabecular smooth muscle and by dilatation of the cavernosal arteries. This causes expansion of the lacunar spaces and entrapment of blood caused by compression of the venules against the ticuna albugina. It is called the corporal veno-occlusive mechanism. Yohimbine, or Yocon, is an alkaloid derivative derived naturally from the West African tree. Yocon is similar to risperidone and has both sympatholytic and mydriatic properties. It is an alpha-2 adrenergic antagonist that affects erectile function by stimulating presynaptic norepinephrine release in the lower nerve centers. Antidiuresis results from the release of the antidiuretic hormone. For treatment principles, cardinal points of treatment, oral PDE5 inhibitors, unless contraindicated, should be offered as first-line therapy for erectile dysfunction. Patients who have failed a trial with a PDE5 inhibitor therapy should be informed of benefits and risks of other therapies, including the use of a different PDE5 inhibitor, intraurethral suppositories, intracavernosus drug injections, vacuum constriction devices, and penile prostheses. The initial dose of L-prostadil, intraurethral suppositories, and intracavernous injection therapy should be administered under a healthcare provider supervision because of the risk of syncope. Non-pharmacological treatment are available. Vascular reconstruction may be appropriate for patients with decreased blood flow. Vacuum constriction devices are safe and effective. A wide variety of implanted penile prostheses have been devised. Specific drugs, the alpha-adrenergic agonist. This includes the most common Flomax. It does cause orthostatic hypotension with syncope, priapism. Patients with severe sulfonamide allergies need to be cautious using this drug, and it may affect pupils of the eye during cataract surgery. It should be used with precautions in cancer of the prostate and BPH. It is a short-acting drug, have an increased incidence of adverse effects because of the rapid increase in drug levels. It does have some drug interaction. It potentiates other alpha-adrenergic blocking agents. Alcohol, alpha blockers, and cimetidine increase the risk of hypotension. Other drugs in this class include drugs such as Proscar, these are contraindicated in pregnancy as well as hypersensitivity. A woman who may become pregnant should not handle, crush, or come in contact with semen of men taking this because of birth defects, and treatment with a drug will decrease serum levels of PSA. It can cause obstructive uropathy, and not all patients have a response, and they need to be monitored carefully. The PDE5 inhibitors, such as Viagra, are contraindicated in patients with hypersensitivity as well as patients taking nitrates. There are warnings for renal and hepatic function impairment. Clearance is reduced, and you should consider lowering the dose. Again, these should not be used in patients who have severe hepatic impairment. Discuss with the patient potential cardiac risk of sexual activity and pre-existing cardiovascular disease. Advise patients who experience symptoms such as angina, dizziness, or nausea upon initiation of activity to refrain from further activity and discuss the episode with their provider. Priapism is an emergency. For erections that last longer than 4 hours, patients should seek immediate medical assistance. They should take 1 hour before expected use. This lasts for 4 hours and only take one per day. This drug may alter color vision temporarily, producing a blue-green hazy vision. For other ED drugs in this class include Muse, Yukon, and Sendra. Again, these might dispose the patient to priapism and should be used with caution. A lot of these medications will be prescribed by urologists, and you just need to be aware of their use. The alpha-adrenergic antagonist, Flomax, androgen hormone inhibitors, the Proscar, PDE5 inhibitors, the Viagras, and the other ED drugs such as Muse, Yukon, and Sendra. Next we'll turn to agents used for urinary incontinence and urinary analgesia. These include drugs such as the anticholinergics, most common oxybutynin, bladder-targeted anticholinergics such as and antispasmodics, as well as cholinergic agonists, posterior pituitary hormones, and urinary tract analgesias. Indications: oxybutynin XL is used for dysuria, neurogenic bladders, overactive bladders, urge incontinence, frequency and urgency. Tolterodine LA is used for overactive bladder, urge incontinence, frequency and urgency. Trospium is used for treatment of overactive bladder with symptoms of urinary urge incontinence, urgency and urinary frequency. Dalphenicin, sulfenicin are used for overactive bladders. Desmopressin is used for primary nocturnal enuresis. Bethanacol is used for urinary retention, and Pyridium is used for dysuria. Botox injections are used in the bladder for those who lose bladder control because of damage to the nervous system due to conditions such as multiple sclerosis, spinal cord injury. However, it's not approved for PC treatment of overactive bladder. So the anticholinergic drugs have many actions. They block muscarinic actions, a subset of the parasympathetic nervous system. The primary associated adverse effects are blurred vision, urinary retention, constipation, dry mouth, tachycardia, and confusion. Anticholinergic medications used for urge incontinence include the tricyclic antidepressants and dicyclomines, such as Bentyl. Anticholinergic drugs inhibit the action of acetylcholine on bladder smooth muscle. This blocks contraction of the bladder and decreases the urodynamic response of the muscle overactivity, which is a problem with urge incontinence. These actions result in increased bladder capacity, delayed desire to void, and diminished frequency of involuntary bladder contractions. Oxybutynin has both direct antispasmodic effects and anticholinergic effects on the smooth muscle. Its direct relaxant effect on smooth muscle is produced by way of the phosphodiesterase inhibition. Two of the newer drugs, darafenicin and solafenicin, have greater affinity for bladder smooth muscle cells than for salivary gland tissue. For the cholinergic agents, bethanacol has an effect that is opposite that of the anticholinergics. It stimulates the parasympathetic nervous system, causing release of acetylcholine at parasympathetic nerve endings. This increases the muscle tone. Increased tone causes a contraction that initiates voiding and bladder emptying, which is useful in some cases of overflow incontinence from urinary retention. Antispasmodics, Favoxate acts as a direct smooth muscle relaxant. This effect causes relief of bladder spasticity and thereby produces increased bladder capacity. Flavoxate also exhibits local anesthetic and analgesic actions. Propethylene effectiveness in urinary incontinence is based on its anticholinergic properties. Biologic toxin, Botox, again, blocks neuromuscular conduction by binding to receptor sites on motor nerve terminals and entering nerve terminals and inhibiting the release of acetylcholine. The toxin is used in urinary incontinence due to muscle overactivity in patients with an inadequate response or intolerance to anticholinergic medications. Currently, it's used primarily by neurologic specialists, but is expected to gain approval for more primary care conditions. Desmopressin, DDAVP, is a synthetic analog of vasopressin that acts as an antidiuretic. Vasopressin is a naturally occurring antidiuretic hormone. Desmopressin is stronger as an antidiuretic than as a vasopressin. In smooth muscle, it decreases urine output for approximately 6 hours. For urinary tract analgesia, pyridine or phenazopyridine is an azo dye that is excreted in the urine, where it exerts a topical anesthetic effect on urinary tract mucosa. It's useful only for the relief of pain. It is compatible with antibacterial therapy and should be used only short-term for 2 days for treatment of urinary tract infections until the antibiotic action reduces the pain. Cardinal points of treatment. Treatment of UTI depends on the type, or urinary incontinence depends on the type of incontinence. Treatment may include non-pharmacological therapies, biofeedback, electrical stimulation, and surgical options. For stress incontinence, off-label treatments include estrogen cream, ring, and pyramine, pseudoephedrine, and duloxetine. For urge incontinence, first line is oxybutylene, darafenicin, solifenicin, taltardine, and trospium. Second line includes TCAs, and third line includes flavoxate and propafenylene, as well as dicyclomine. For non-pharmacological treatment, this is the mainstay of treatment for urinary incontinence. These minimally invasive management techniques include fluid management, bladder training, bladder retraining, and pelvic floor muscle relaxation. Pharmacological treatment, if female stress incontinence, alpha-adrenergic agonists are used. Some research supports the use of estrogen topically as a first-line therapy in elderly women with atrophic vaginitis that contributes to the incontinence. Pseudoephedrine, 30 to 60 milligrams, up to 4 times a day, can also be used. This is off-label, although high blood pressure is a risk for some individuals. TCA increases bladder outlet resistance, which allows for better storage of urine. However, TCAs are not recommended for use in older persons because of the orthostasis and central and peripheral anticholinergic side effects. And pyramine is the most commonly used agent, 25 milligrams orally at bedtime. Onset of effect may take several weeks. In urge incontinence, first-line pharmacotherapy consists of oxybutylene, darafenicin, solifenicin. Second-line medications are the TCAs, and bethanyl, a urinary cholinergic, is used for short-term therapy of urinary retention. The cause of the retention must be diagnosed and treated first. Phenoparidine is used for interstitial cystitis or perineum, and this is only used short-term for 2 days until the antibiotics take effect. How do we monitor these patients? Clinical effectiveness must be monitored through the use of bladder diaries that documents voiding patent incontinent episodes, urge symptoms, and urine volumes. You need to monitor for anticholinergic side effects as well as cardiovascular status in patients with cardiac disease. For patients' variables, geriatric patients, elderly patients are extremely sensitive to the anticholinergic effects. Both confusion and extreme cardiac effects are commonly seen. Constipation xerostonia, and many other minor side effects may adversely affect their quality of life. For pediatric patients, anticholinergics, oxybutylene is not indicated for children younger than 5 years of age. Safety and efficacy of other products in children younger than 12 years has not been established. Oxybutylene may cause hallucination and agitation in children. Cholinergics are not indicated in children. Primary nocturnal enuresis is common in children. Desmopressin may be used in children 6 years of age or older. For pregnancy and lactation, oxybutylene, lavoxate, lactation, is a category B. Lactation not known. Desmopressin, lactation is probably safe. For category C, you've got the tolterodine, and is possibly safe in lactation. For gender, causes of incontinence vary by gender, and the causes need to be identified. For patient education, careful patient teaching regarding response to side effects is necessary. The patient should avoid driving or participating in hazardous activities until the reaction of the drug is known. A dry mouth may be relieved by sugar-free gum or hard candy. Patients should be cautioned to maintain adequate fluid and fiber intake to prevent constipation. The patient should avoid hot environments to prevent suppression of the sweat gland activity and increase their risk of heat stroke. This is particularly a problem for the elderly because of age-related reduction in sweat glands. Alcoholic beverages should be avoided. Elderly or debilitated patients should be warned that they may experience agitation, confusion, excitement, or drowsiness with usual dose. If this happens, they should stop taking the drug and notify their practitioner. Postural hypotension and tachycardia may occur during early therapy, and you need to warn the patients of this. Bethanechol should be taken only on an empty stomach to avoid side effects of nausea and vomiting. And because orthostatic hypotension may occur, which may lead to falls and fractures, patients should be taught how to change positions slowly. Again, the specific drugs, the anticholinergics, include the oxybutylene chloride, the ditropan or ditropan XL, oxytrol transdermal patch, topical gel or transdermal system. Other drugs include the antispasmodics, the cholinergic agonists, the posterior pituitary hormones, and the urinary tract analgesias. Now we're going to move on to contraception. We're just going to briefly talk about this. There are many different medications that are available for prevention, and you need to look these up when you're prescribing to ensure that you know the dosages of the combination pills as well as the medication in each. Progesterone is secreted in significant amounts, 20 to 30 milligrams per day, in the second half of the normal menstrual cycle by the corpus luteum. During the first half of the cycle, estrogen dominates and progesterone is secreted in minute amounts, 2 to 3 milligrams per day, by the ovaries and adrenals. During pregnancy, the placenta secretes very large amounts of progesterone, and these hormone levels are what we use to judge what medications to place the patient on. There are many different drugs available, combination estrogen and progestin pills. We have the oral medications, the monophasics, the biphasics, the triphasics, and fourphasics. We have the oral extended cycles, the contraceptive patch, and an intravaginal ring. There are also the progestin-only pills. These are used for emergency contraception, progestin-only oral contraceptives, the progestin-only injection, progestin subdermal implants, and the intrauterine device. Progestin receptor modulators are also used, as well as non-hormonal contraception such as the IUD. Indications include the prevention of pregnancy. These are used for acne vulgaris, specifically the orthotricycline, the orthotricycline low, the orthocycline, and the estrostep iron, as well as Yaz. They're also used for emergency contraception, such as Plan B, One Step, Ella, Next Choice, or Paragard. They're also used for heavy menstrual bleeding, Mirena or IUD. Unlabeled uses include use for anemia prevention, improvement, resolution of amenorrhea, decrease menorrhea, dysmenorrhea, improve cycle control, relief of ovulatory bleeding, endometriosis, a dysfunctional uterine bleeding, a reduction of premenstrual syndrome and menstrual dysphoric disorder symptoms, decreased risk of benign breast disease, decreased ovarian cysts, ovulation pain relief, hirsutism, perimenopausal symptom control, acne vulgaris, female hypogonadism, emergency contraceptives, improvement of menstrual migraines, and reduction of endometrial and ovarian cancer risk. What are the mechanism of action? Looking at the combined oral contraceptive pills, they can be categorized as monophasic, multiphasic, such as biphasic, triphasic, fourphasic, and extended cycle pills. Monophasic pills contain identical amounts of estrogen and progestin in all 21 active pills. Multiphasic pills vary the amount of estrogen, progestin, in or both over the active pill days in an attempt to mimic the normal menstrual cycle or minimize side effects. Extended cycle pills have a longer treatment cycle to provide fewer menstrual periods. The basic methods used to initiate combined oral contraceptive pills are fairly the same. For a quick start usage, the patient should start the combined oral contraceptive pills using a quick start method by taking the first pill in the pack on the day of our office visit and use a barrier method such as condoms for the first 7 days. The patient should be reasonably sure she's not pregnant before starting the pill. If she has not had unprotected intercourse in the past if she's not had unprotected intercourse in the past 2 weeks, an in-office pregnancy can be performed. If she has had intercourse more recently, the patient can start the pill and come back to the clinic for a pregnancy test in 2 to 3 weeks, or take home a pregnancy test at that time. If she is pregnant, taking combined oral contraceptive pills will not negatively impact early pregnancy. Using the quick start method rather than the first day or Sunday start method decreases the chance of the patient conceiving in the interim, forgetting pill instructions, or failing to fill the prescription. Due to these factors, the quick start method is now the preferred method for starting birth control. The first day start, starting COCPs within 24 hours of the onset of menses affords the best contraceptive efficacy during the first cycle. Backup or concurrent use of second form of contraception is not necessary for the first day start. For the Sunday start, the patient starts COCPs on Sunday of or following the period onset. Backup contraception for 7 days is necessary if menses did not begin on a Sunday. The only advantage of the Sunday start is avoidance of periods on the weekend. Although this was the most common used start methods for a number of decades, it's not generally recommended due to trouble getting refills on the weekends and because many women work outside of the home and choose to avoid menses on work days. Despite this, many manufacturers still label the first pill in a pack as a Sunday pill, so the provider should become aware of this method. When should the patient take the pill? The patient should take one pill every day at the same time. If using a 28-day pill pack, they start the next pack as soon as the last pack is finished. If using a 21-day pill pack, they stop the pills for 7 days and start the next pack the next day. If nausea occurs, switch to the opposite time, morning or to evening, or take with food. Missed pills, especially at the beginning or the end of the pack, may allow ovulation, and unintended pregnancy can occur. Increasing the time between active pill increases the risk of ovulation. Encourage associating pill taking with a daily routine, such as brushing the teeth or mealtime, to avoid any missed pills. Some women set their cell phone alarms to remind them to take their pills. If a pill is missed, one pill is missed, the patient should take the missed pill as soon as possible. They should take the next pill at the regular time. If the forgotten pill is not discovered until the next pill is due, they should take both pills at the same time. Use of condom or diaphragm for backup contraception for 7 days is optional but suggested. If 2 pills are missed in a row, they should take 2 pills as soon as possible, take 2 pills the next day, and use backup method for 7 days. If 3 or more missed pills for the first day starters, they need to throw out the rest of the pack and start a new one on the same day. For Sunday starters, they need to take 1 pill every day until Sunday. On Sunday, they throw out the remaining pills from the pack and start a new pack that same day. The patient may or may not have a period that month. Order a sensitive pregnancy test. If 2 periods are missed, use backup contraception for 7 days after the missed pills. If 2 or more pills are missed at the beginning or the end of the pack, a total of 9 or more missed pills during a pill-free interval, they need to use emergency contraceptive pills, then restart a new pill pack and use backup for 7 days. A backup method, all patients should have a backup method of contraception available, such as condom or a spermicide, as well as a Plan B, ED. Sunday starters need to use a backup method for the first 7 days during the first pack of pills. First day starters do not need a backup method during the first cycle. The backup method should be readily available in case of missed pills, vomiting or diarrhea, or discontinuation due to serious pill warning signs. New starts may be instructed to use backup for the entire first cycle, while side effects such as nausea and missed pills are more common. This applies to combination pills only, not the POPs. For extended cycle pills, the FDA has approved a variety of extended cycle monophasic, continuous 84-day active pill, 7-day placebo pill regimens that contain levonorgestrel and ethinyl estradiol. This regimen is as effective in preventing pregnancy as the conventional 21 7-day regimens. Withdrawal bleeding is comparable between the different regimens. No endometrial pathology has been found, and the side effect profile is similar in extended and conventional regimens. These drugs are predicted to be attractive to women who will have only 4 menstrual periods per year. Additional manufacturers are producing pills with shortened pill-free intervals, and many clinicians use evidence-based practice to support the practice of prescribing standard monophasic combined pills with instructions to patients that explain that they can minimize cycling by taking active pills daily without a placebo or pill-free interval. For the transdermal system of hormone administration, this bypasses the liver, eliminating the first pass effect. It is a benefit of being convenient, requiring a weekly application of the transdermal patch instead of oral administration of the pill. The main disadvantage is that the adhesive can cause mild to moderate skin irritation. Transdermal contraceptives have been up to 99% effective when used correctly, with a lower incidence of some side effects than seen with oral contraceptives. The FDA has released a warning stating that the increased steady state of ethanol estradiol found in patch users versus pill users may increase the incidence of adverse events, including venous thromboembolism. However, studies have been conflicting, with results ranging from no increase to double the risk. The patch is applied once a week for 3 weeks to a different area of the skin to each application. This is followed by a 1-week patch-free interval. The old patch is removed and a new one is applied. The cycle is then repeated. Patches can be applied to clean skin that is free of any lotions or other topicals on the buttocks, abdomen, upper, outer arm, and upper torso, where they will not be rubbed by tight clothing. If the patch becomes partially or completely detached, it should be reapplied or a new patch applied. The patient should not cut the patch. They should not reapply a patch if it's no longer sticky. Supplemental adhesive should not be used. Single replacement patches are available to patients from pharmacies. If a patch has been discovered to be loose or has come off, patients should use backup method of contraception for 7 days. Patients can switch from oral contraceptives to the patch beginning when they would start a new pill pack. Clinical trials have suggested that the transdermal system may be less effective in women with body weights greater than or equal to 198 pounds than in women with lower body weights. There's also the vaginal ring. This is an intravaginal ring where ethanol, estradiol, and estrogenestrol hormone are packaged in the ring itself, from which the medication is slowly dissipated. Its use is correlated with pregnancy rate of 1 to 2 pregnancy per 100 women years. The ring is placed into the vagina by the patient. Its advantage is that it requires only monthly administration. Of the self-administered methods, this one is very convenient and private. It also avoids the first pass phenomenon, thereby allowing for a lower dose and causing little risk of adverse reactions. The ring is compressed and is inserted into the vagina. Its exact position in the vagina is not critical. It is removed 3 weeks later by hooking the index finger or the index and middle fingers around the ring to pull it out. The discarded ring should be placed into a foil pouch and discarded, not flushed. Patients should be switched from a combination oral contraceptive to the ring by insertion within 7 days after the last active tablet. No backup method is needed. Switch from the progestin-only method by starting on the same day the previous method has stopped. Use an alternative method of contraceptives for the first 7 days. Treatment principles, cardinal points of treatment. Choosing a hormonal contraceptive must be individualized. The patient's wishes are integral in selecting in the selection process. Consider a health history, experience with hormonal contraceptives, concomitant medications, and preferred mode of administration. Choose a method that is most likely to encourage adherence. There is a algorithm for choosing a product, which I will talk about in a moment. Many of the oral contraceptive products are available in generic form. Inform the patient that packaging and the look of the pills may change without change in effectiveness. Although some side effects are more likely to occur with certain pills than others, patients' response is variable. Be sure the patient knows that they can contact you to discuss any side effects, and that most of these can be eliminated by making minor changes. Stress clinician-patient collaboration and communication that can help prevent patients from simply taking themselves off the hormonal method without instituting backup contraceptive plan. Stress to the patients that hormonal contraceptive will not prevent sexually transmitted infections, and that for patients, many patients, barrier protection is needed. This is an algorithm for choosing which contraceptive is useful. The patient comes and desires hormonal contraception. You need to obtain a history, a blood pressure, a physical exam, lab work as well. You need to look for risk factors versus healthy non-smoker. If the patient does have risk factors, you need to look for whether the history of estrogen-related side effects from combined oral contraceptive pills, such as nausea or breast tenderness, has occurred. If they're a smoker greater than 35 years of age or a smoker of 35 years of age or less, you need to encourage smoking cessation and counsel regarding relative risks. For the patient with side effects, consider 20 micrograms of EE or estrophasic combined oral contraceptive or progestin-only methods. For patients with risk factors and smokers greater than 35 years, consider progestin-only methods. For smokers less than 35 years old or healthy non-smokers, you need to look whether pregnancy is desired within the next 2 years, desires pregnancy within the 2 years, or has acne or other adrenergic characteristics. If they do not desire pregnancy in the next 2 years, any low-dose combined product or Depo-Provera would be useful. If they desire pregnancy within 2 years, any low-dose combined oral contraceptive pill, or they have other androgenic characteristics. Orthotricycline is the first choice, indicated for acne. All combined oral contraceptive pills and Depo-Provera lower testosterone. You should monitor patients 3 months after initial prescription, review the blood pressure, compliance, and side effects. Again, treatment principles for the combined oral contraceptive pills. They can be categorized as monophasic, multiphasic, and extended cycles. Monophasics contain identical amounts of estrogen and progesterone in 21 active pills. Multiphasic pills vary in the amount of estrogen, progestin, or both over active pill days in attempts to mimic the normal menstrual cycle. Again, the quick start, extended cycle pills, transdermal systems, and vaginal rings. Emergency contraceptive pills are known as the morning after pills. Emergency contraceptives are thought to interfere with ovulation. Other possible actions include disruption of the endometrium to inhibit implantation, alteration in tubal transport of sperm or ova to prevent fertilization. Emergency contraceptives are not effective with existing pregnancy. These progestin-only pills taken within 72 hours of unprotected intercourse reduce the risk of pregnancy by at least 75%, although data suggests that the efficacy may extend to 120 hours. The sooner emergency contraceptive is initiated, the more effective it will be. Following emergency contraceptive use, the next menstrual period may start a few days earlier or later than usual. Some spotting may occur before the next period. If the period does not start within 3 weeks, the patient should contact their healthcare provider for a pregnancy test. Progestin-only emergency contraceptive is effective and has few side effects and no contraindications. It is not an abortion in that it does not disrupt an established pregnancy. Plan B, one step, and next choice are available over the counter for women 17 years of age or older. A prescription is required for women younger than 17 years. Ella is only available with prescriptions. Progesterone-only mini pills The benefits of these include avoidance of estrogen-related side effects, safe and effective for lactating women. They may be started immediately postpartum, and safe for patients with contraindications to estrogen. These are also called mini pills. POPs are used primarily in breastfeeding women and women with contraindications to estrogen. You should need to advise the lactating woman to notify when she stops nursing so she can be switched to a combined oral contraceptive. There's no increase in risk for thromboembolic events with the progestin-only pills. They are more effective when they inhibit ovulation. You need to explain that the more disrupted their bleeding pattern, the more likely that it is that ovulation is inhibited. If the patient cycles regularly, she's probably ovulating and should use a backup method of contraception. The patient should report to the provider any prolonged episodes of bleeding, amenorrhea, or severe abdominal pain. You need to start the pill on the first day of menses, use a backup method for 7 days. The changing from CPs to POPs, omit the pill-free week and start the POPs immediately after stopping active combined oral contraceptive. The patient should take the pills at the same time each day. If the pill is taken more than 3 hours late, a backup method must be used for the next 48 hours. No pill-free interval occurs when one 28-day pack is finished, another pack is started the next day. All pills are in the pack are active pills. Counseling on bleeding changes and the need to take all 28 pills helps prevent discontinuation and enhances effectiveness. For the subdermal implants, these are progestin-only contraceptive. They're available as an implantable device in a single rod implant that contains etonogestrel, desoestrel metabolites that are less androgenic and exhibit more progestational activity. Insertion and removal takes about 2.5 minutes. These are designed to inhibit ovulation during the entire treatment period. Although their use is approved for 3 years, they may provide contraceptive protection up to 5 years. Follicular activity without ovulation in the presence of nearly normal estradiol levels has been seen with this method. Because of this, women may develop palpable but seldom symptomatic physiologic ovarian cysts, which usually resolve spontaneously and do not require intervention. No long-term effects on fertility have been noted in implant users. After removal of the implant, concentrations of estradiol are undetectable within 1 week. Advantages of implants include their high efficacy rate, long-term action, ease of use, rapid onset, and protection against ectopic pregnancy, low relative costs, and possible protection against urogenital tract infections. Possible disadvantages include menstrual irregularities, which usually improve over time, provider-dependent difficulties with placement and removal, lack of protection against sexually transmitted infections, and side effects for some women, including headaches, acne, breast tenderness, weight and mood changes, ovarian cyst formation, and galactorrhea, which is breast milk expression. Contraindications for contraceptive implants include acute thrombophlebitis, a thromboembolic disease, undiagnosed genital bleeding, acute liver disease, benign or malignant liver tumors, and known or suspected breast cancer. Implant is an important option for women whom combined OC hormones may not be indicated, such as cigarette smokers older than 35 years and patients with diabetes mellitus with vascular disease. Hypertriglyceridemia, history of stroke, heart attack, or deep vein thrombosis, gallbladder disease, and vascular headaches or migraine headaches with neurological symptoms. Depo-provera or depomedroxyprogesterone, sometimes referred as Depo, is a long-acting injectable contraceptive that is especially useful in patients who have any condition that is worsened by a menstrual cycle, such as anemia, dysmenorrhea, or menstrual migraines, in those with sickle cell anemia or seizure disorders, and in women with an increased risk of endometrial cancer or ovarian cancer. Because of its potential suppress of estrogen, some clinicians use it to manage fibroid tumors. Patients who take Depo experience less bleeding. They may be amenorrhea, making an excellent choice for anemic patients. Benefits include convenience and ease of compliance. There are a few drug interactions that do occur. Depo is not affected by medications that induce liver metabolism. The medication is available in vials and pre-filled syringes of 150 milligrams IM, as well as pre-filled syringes of 104 milligrams sub-Q injection. When IM injection is given, it should be administered by Z-track technique into the gluteus maximus or the deltoid muscle. The area of the injection should not be massaged because it can lower the effectiveness. Although contraceptive efficacy can be ensured only when injections are given every 3 months, some Depo may remain in the bloodstream for 6 to 9 months. The initial injection should be given during the first 5 days of menses to ensure the patient is not pregnant. Timings of injections, they may be given every 12 weeks, plus or minus 7 days, but they can be given earlier if a woman has spotting. Although fertility may be delayed for up to a year after the method is continued, contraception efficacy cannot be guaranteed if the injection is given late. If a woman presents later than 13 weeks since her last injection, Depo may be given if she has not had intercourse outside the 12-week window. Otherwise, she will have to maintain abstinence for 14 days or so. A reliable pregnancy test can be given or must return for injection during menses, whichever is sooner. A backup method: if Depo is given during the first 5 days of menses, no backup method is needed. If it is given at any other time in the cycle, backup is necessary for the first 2 weeks. For the intrauterine device, there are 2 types available. They combine the mechanical protection of the device with low levels of progestin that minimizes menstrual bleeding. The IUD is effective for 5 years and has had an additional indication for heavy menstrual bleeding. The non-hormonal mechanical copper T IUD method is effective for 10 years and may be used for emergency contraception within 7 days of unprotected intercourse. IUDs have additional contraindications for those for oral contraceptives. They must be inserted by specialty trained healthcare providers. Patient variables: age older than 35. COCPs are appropriate throughout the reproductive years. Non-smoking women may continue until menopause on any combined oral contraceptive pill that contains 35 micrograms or less of EE. Smoking women should not take COCPs after the age of 35. Perimenstrual menopausal women without other contraindications are good candidates for COCPs because of their non-contraceptive benefits. These help to prevent some of the adverse sequelae that occur during perimenopause, such as endometrial hyperplasia, hot flashes, and vaginal atrophy. It is important to determine when a woman has gone through menopause and can discontinue combined oral contraceptive pills. Unfortunately, there is no definitive test to determine when a woman on hormonal birth control is menopausal. Some experts recommend continuing hormonal contraceptives until the age of 54 or 55, when the risk of pregnancy would be very low. Then condoms or non-hormonal methods can be used until the patient can accurately evaluate for menopause. For those with a family history of breast or ovarian cancer, when compared with women who have never used COCPs, women with BRCA1 or BRCA2 mutations currently using low-dose regimens do not have an increased risk of breast cancer. However, some studies have found that long-term use in women with these mutations, especially before the first full-term pregnancy, may increase incidence of breast cancer. Personal histories of benign breast disease or family histories of breast or ovarian cancer, including the BRCA1 or BRCA2 mutations, are not a contraindication to oral contraception. BRCA mutations greatly increase the lifetime risk of ovarian cancer in carriers. Because COCPs are associated with significant decrease in ovarian cancer risk, this could provide a potential benefit to women with BRCA mutation. For those patients who are pregnant and lactating, conjugated estrogen and amidroxyprogesterone are designated as FDA Category X. However, contradictory data indicate that no risk of birth defects is present when a woman becomes pregnant while using estrogen-based oral contraceptives. Data regarding risk from contraceptive doses of progestins are inconclusive. CDC's report suggests that after giving birth, women should wait 3 or more weeks before starting the use of birth control pills to avoid risk of serious potential fatal blood clots. Those who deliver via C-section should delay taking contraceptives for at least 6 weeks because of the risk of increased risk of blood clotting. For progestin-only birth control methods are recommended until at least 21 days postpartum because these women are in hypercoagulable state for weeks after pregnancy. In women with additional risk factors for DVT, including cesarean section and obesity, combination contraceptives should be withheld until 42 days postpartum. Newer guidelines report also suggest that women who breastfeed refrain from using hormonal birth control methods due to their potential effect on lactation. Because progestins promote breast milk production while estrogen decreases the quality and quantity of milk, progestin-only methods are recommended for lactating women who desire hormonal contraception until milk production is well established. For those women who have migraines with auras, have a relative contraindication to combined oral contraceptive pills, many studies have identified that people who suffer from migraine with auras are at increased risk for stroke. However, most studies regarding combined oral contraceptive pills in women with migraines do not differentiate between migraine and with and without an aura. Because risk of stroke is generally low, combined oral contraceptive pills may be considered for migraine sufferers who, without auras, who are under 35 and do not smoke. If COCPs are offered to women with any type of migraine, they must be closely monitored. For patient education of the combined oral contraceptive pills, and progestin-only pills, the patient must demonstrate use of the pill package, have the patient give a return demonstration. Pills must be taken exactly as directed. They must use a backup method for at least 48 hours when progestin-only oral contraceptives is taken more than 2 to 3 hours late. For COCPs, they need to follow the treatment principles. Stress that the progestin-only pills require a constant daily dose. No placebo pills or pill-free interval is provided. The pill does not protect against STDs or HIV virus. Stress the importance of use of male or female condoms with every act of intercourse that may pose a risk for STDs. Instruct the patient to stop taking pills immediately and contact their healthcare provider if any serious adverse reactions occur. How do you monitor these patients? The initial visit should include assessment of weight and blood pressure. Although a clinical breast examination, pap smear, pelvic exam, and STD testing should be offered to patients depending on the age, the World Health Organization, Planned Parenthood, and the American College of Obstetrics and Gynecologists do not recommend requiring these procedures when providing contraceptive counseling to patients. Some clinicians schedule follow-up visits 3 months to check blood pressure and weight gain or loss and review side effects and warning signs. Yearly monitoring include weight and blood pressure assessment, clinical breast exams, pap smear, pelvic exams, and STD testing as indicated. Patients at high risk for disease, those with personal or family history, may undergo a baseline lipid profile and fasting glucose at the initial exam and yearly thereafter. Patients are considered at high risk for thromboembolism if they are smokers or are overweight. Counsel patients that they must not smoke while taking OCPs. Again, this is a list of absolute contraindications, including hypersensitivity, thrombophlebitis, thromboembolic disorders, history of DVTs, cerebrovascular disease, MIs, coronary artery disease, known or suspected breast carcinoma or estrogen-dependent neoplasm, carcinoma of the endometrium, hepatic adenomas, carcinomas, acute liver disease, undiagnosed abnormal genital bleeding, known or suspected pregnancy, cholestatic jaundice of pregnancy or jaundice with prior pill use, and hypersensitivity. For warnings, smoking, cigarette smoking increases the risk of serious cardiovascular side effects. The risk increases with age and with heavy smoking and is quite marked with women over the age of 35. Women who use OC should not smoke. Thromboembolism, be alert of the earliest symptoms and discuss with the patient. For cerebrovascular disease, OCs increase the risk of thrombotic and hemorrhagic strokes as well as vascular disease. A decline in HDL and an increase in triglycerides have been seen. Ocular lesions, retinal thrombosis has occurred. Monitor for unexplained loss of vision, onset of proptosis or diplopia, papilledema, or retinal vascular lesions. Carcinoma, there is an increased incidence of breast, endometrial, ovarian, and cervical cancer. Drugs that reduce efficacy of combined oral contraceptive pills. These include the cytochrome P450 enzyme inducers, cause rapid breakdown of estrogen and progestin, and may decrease the effectiveness. Patients should consider other methods when on these medications, such as anticonvulsants, phenobarb, dilantin, primidone, tegretol, trileptal, anti-tuberculosis medications, rifampin, antifungals, grisophulin, and protease inhibitors, St. John's worts, and modafinil. Drugs that may reduce efficacy of combined oral contraceptive pills include antibiotics, although the evidence is controversial, primarily tetracycline, amoxicillin, ampicillin, and flagyl. May eliminate gut flora, causing a decrease in the amount of hormone absorbed from the intestine or interfere with enterohepatic recirculation. Long-term antibiotic use is far less likely to be associated with this effect. Patients should be cautioned to use a barrier method during COCP cycle when a new course of antibiotics is initiated. Patients taking protein pump inhibitors or who have undergone gastric bypass surgery should not be prescribed OCPs because of the problems with drug absorption. Drugs that may increase estrogen effects include megadoses of vitamin C, up to 2,000 milligrams and up, has been shown to increase the amount of circulating EE by inhibiting liver enzymes that metabolize the steroids. Women who take 1,000 milligrams or more of vitamin C per day who are taking low-dose COCPs actually may be receiving high-dose pill estrogen. When the patient stops taking vitamin C, she may experience spotting as estrogen levels decrease. Taking vitamin C at different times from the COCP administration will not prevent this effect. Drugs that may have altered pharmacokinetics with combined oral contraceptive pill administration, OCPs may decrease clearance of benzodiazepines, corticosteroids, phenolphthalein, and aminophenolphthalein. Lower doses of these medications may be indicated. The effects of tricyclic antidepressants, beta blockers, and alcohol may be increased. Analgesics such as acetaminophen may have decreased pain-relieving effects. You also need to consider effects of complementary and alternative therapies on OCPs. Again, the specific drugs include this combination oral contraception, other drugs in the class, progesterone only, intrauterine devices, and Depo-Provera. We're going to quickly review some drugs used for breast cancer. The goal is to familiarize the primary care provider with the medications that some patients may be taking for the treatment of breast cancer. Most of these drugs are given on a long-term daily schedule and may interact with other medications prescribed for chronic diseases or acute illness. Most of these will be prescribed by oncologists, but you need to be aware of these medications. These include the anti-estrogens, the SERMs, such as tamoxifen, estrogen receptor downregulators, and estrogen receptor modulators, which are selective. There are also the aromatase inhibitors, aromatase inactivators, and these are indicated for breast cancer treatment. Mechanism of action: the anti-estrogens. Tamoxifen is a non-steroidal selective estrogen receptor modulator. It competes with estradiol at binding sites in the cell nucleus in breast tissue, altering gene transcription and protein synthesis. This inhibits the growth of estrogen-dependent tumor cells. Tamoxifen acts as an estrogen agonist and has a favorable effect on plasma lipid levels and bone mineral density. However, it may be linked to endometrial malignancy and thromboembolism. Fulvestrant is an estrogen receptor antagonist that competes with estradiol by binding to estrogen receptors. This medication helps to downregulate the ER protein in human breast cancer cells. Tromethamine binds to estrogen receptors and exerts an anti-estrogenic effect. It competes with estrogen for binding sites in cancer, blocking the growth-stimulating effects of estrogen in the tumor. Aromatase inhibitors blocks the aromatase enzymes from converting aldosterone to estrone and testosterone to estradiol. Many breast cancers also contain aromatase. Anastrozole is a potent and selective nonsteroidal aromatase inhibitor. It lowers serum estradiol concentrations. Letrozole inhibits the aromatase enzyme by competitively binding to the heme of the cytochrome P450 subunit of the aromatase enzyme, resulting in the reduction of estrogen biosynthesis in all tissues. It is a more potent inhibitor than the anastrozole. Finally, the Emestane is a steroidal aromatase inactivator. It acts as a false substrate for the aromatase enzyme that binds irreversibly to the active site of the enzyme, causing its inactivation. This results in decreased circulating estrogen concentrations. For the cardinal points of treatment, therapy depends on accurate early diagnosis. SAI often is recommended over tamoxifen. Therapy depends on whether or not cancer is metastatic and whether the patient is premenopausal or postmenopausal. For pharmacological treatment, all medications have their primary effect of reducing estrogen in the body. Thus, they may have characteristics in common and are effective primarily for estrogen-sensitive cancer. Tamoxifen was approved in 1994. Tamoxifen is used for the prevention of breast cancer in women who have increased risk. The benefits are weighed against the risks of the drug. It has a black box warning because of the risk of increased endometrial cancer, stroke, pulmonary embolism, and deep vein thrombosis. As with all drugs, the benefits should be weighed against the risk of drug use. Tamoxifen is used for the treatment of patients with breast cancer when the axillary node is negative after total or partial mastectomy or radiation of tumors greater than 1 centimeter. It's recommended for the treatment of node-positive breast cancer in postmenopausal women after total mastectomy or after radiation, and in advanced estrogen receptor positive metastatic disease in men or women. Women who took tamoxifen for 5 years after breast cancer diagnosis were nearly 40% less likely to have the cancer return. Protection that lasted for more than a decade after they stopped taking the drug. Current tamoxifen therapy is associated with a significantly increased incidence of diabetes in older breast cancer survivors, but aromatase inhibitors use has no known association with diabetes. Zoltamox is a liquid formulation of tamoxifen that has been developed to help improve compliance with medications when the effects of radiation, surgery, or chemotherapy has made it difficult for the patient to swallow the pill form of tamoxifen. Additionally, this formulation is helpful for some people who prefer liquid medications rather than pills, or just want to reduce the number of pills they have to take. Clinicians may have patients fill out a simple 10-question survey to help assess if they have difficulty swallowing. This can be done. This EAT-10 is a clinically validated tool available at www.swallowingdifficulties.org and provides helpful. The results are helpful in stimulating discussions about swallowing problems. The newer anti-estrogen drugs have been associated with fewer adverse reactions. Currently, these are used for treatment of patients with breast cancer. Aromatase inhibitors convey many of the same risks as the anti-estrogens. Currently, they are used only for the treatment of breast cancer. Recent studies have shown that they are effective in reducing the rate of invasive breast cancer in postmenopausal women at moderately increased risk, although this is not yet an FDA-approved indication. How do you monitor these patients? For the anti-estrogens, they need routine gynecological care, routine eye care, liver enzymes, CBC, monitor lipids in patients at risk for elevated lipids, calcium, especially during the first weeks of treatment, and monitor blood glucose levels to monitor for development of diabetes mellitus. For the aromatase inhibitors, they too need routine gynecological care, liver enzymes, CBC, bilirubin, creatinine, bone mineral density, cholesterol, total, and LDL. For patient variables, for geriatric patients, tamoxifen and anastrozole, no overall difference in tolerability. For pediatric patients, safety and effectiveness has not been studied in children. Tamoxifen and anastrozole has been used to treat precocious puberty. Long-term effects are not known. Pregnancy and lactation, these are considered Category D. They may cause fetal harm. It is not known whether these medications are excreted in breast milk. For race and gender, tamoxifen is used to treat both men and women with breast cancer. For patient education, the patient needs to report immediately any abnormal vaginal bleeding or changes in vaginal discharge. They need routine gynecological care. Patients should not become pregnant. This medication may cause fatal harm, and regular blood work, including liver function tests and total blood counts, is important. Again, most of these patients are going to be followed by oncologists, and you just need to be aware of these medications. Finally, the specific drugs, again, the anti-estrogens, the tamoxifen. Patients, contraindications for this drug is sensitivity to the drug, Coumadin therapy, or a history of DVT or PE or pregnancy. There is a black box warning issued for thromboembolic effects of tamoxifen. There is an increased incidence of thromboembolic events, including deep vein thrombosis, pulmonary embolism, and stroke. These can be fatal. This medication can be carcinogenic. There is an increase in frequency of endometrial cancer and uterine sarcoma. Increased hepatocellular carcinoma also may be seen. There is also some non-malignant effects of the uterus: hyperplasia, polyps, fibroids, ovarian cysts, endometriosis, menstrual irregularity or amenorrhea. Visual disturbances including corneal changes, cataracts, and retinopathy have occurred. Hypercalcemia has occurred in patients with bone metastasis, and hepatic effects include elevated liver enzymes, hepatitis, and hepatic necrosis. This is why you need to perform periodic LFTs. Precautions with patients with leukopenia and thrombocytopenia. These may result from tamoxifen. You need to perform periodic CBCs. Hyperlipidemias may occur. Consider monitoring for these. Some of the adverse effects include hot flashes, nausea, vomiting, weight gain or loss, fluid retention, vaginal discharge, irregular menses, skin rash, and headaches. Infrequent adverse reactions include hypercalcemia, erythema multiforme, Stevens-Johnson syndrome, bullous sphygmomatoid, and hypersensitivity. Changes in liver enzymes are important adverse reactions. Tamoxifen is a major substrate of the cytochrome P450, 3A4, 2CY, and 2D6 enzyme systems. If taken with warfarin, an increase in prothrombin time occurs, and so it's contraindicated. For Faslodex, similar contraindications: hypersensitivity in pregnancy. It could cause fetal harm, and not suggested in pregnancy. The tormeferin, again, hypercalcemia and tumor flare may occur during the first few weeks of treatment, along with diffuse musculoskeletal pain and erythema with increased size of tumor lesions that later regress. They're often accompanied by hypercalcemia. Fetal harm in pregnancy, and do not use in patients with history of thromboembolic events. This medication is also a major substrate of the CYP450, 3A4, so they may react with many medications. Thiazide diuretics may increase the risk of hypercalcemia with variostrone and should not be used together. For the aromatase inhibitors, again, can cause fetal harm, should not be used in pregnancy. Pregnancy must be excluded. Used with caution in patients with elevated total LDL cholesterol. Increases the incidence of hepatocellular adenoma and carcinoma, and uterine stromal polyps in females, and thyroid adenoma in males. Caused infertility in rats as well. Drug interactions that should not be given with tamoxifen. Tamoxifen reduces the anastrozole levels, and do not give with estrogen-containing therapies.